Hello, good afternoon everybody in Newfoundland and Labrador, and good morning to everyone in BC. I'm sorry for the little late start. We had a few participants who had a bit of trouble logging into Blackboard Collaborate, so they are joining us by phone. My name is Eva Vod. I'm the Training and Capacity Lead for Annual Support. And I'm pleased to welcome you all today to our webinar about knowledge brokering. Just for those who are new to Blackboard Collaborate, we have enabled the microphone and your webcam. You are able to communicate with us via the chat box, and you're also able to vote. So there's in the participant box you can find your voting option, and below that you can find your chat option. If you have any trouble hearing us, please let us know as soon as possible. I would also like to remind you that this webinar is being recorded, so the recording will become available after the webinar, as well as the slides. So our first speaker of today is Amanda Hall, who is our own knowledge translation lead. And we are very pleased to have Alison Holmes here today with us, knowledge translation specialist from BC Support, and they will introduce themselves. So I'm going to now hand it over to Amanda, and I hope you have a great session. If you have any questions, please feel free to post them in the chat box.
Thank you, Eva. So as Eva mentioned, I'm Amanda, and I work with the Newfoundland Support Unit as the Knowledge Translation Lead here. And we realize that many of the listeners today on the webinar may have a broad range of experience or understanding of KT, a knowledge translation. So I'm just going to give you a brief introduction and the definition, some of the domains, and the approaches for knowledge translation before I hand it over to Professor Alison Holmes from the BC Support Unit to discuss more in detail about knowledge brokering as well as the major approaches for how we actually do KT. So yes, like I said, we'll start with the definition, followed by a few of the main domains for knowledge translation, and then some of the common approaches. So I guess the most important thing to note is that knowledge translation doesn't have one specific definition. There are many that are used by different groups. We've presented the one here from the CIHR, which is a very broad definition, and they are trying to make sure it encompasses quite a range of concepts. So they've defined knowledge translation as the exchange of knowledge, the synthesis of knowledge, and the application of knowledge among and between researchers and the knowledge users. And the primary aim of that is to accelerate the use of research evidence to help improve outcomes for patients, or how health systems work and how they function, and how we can produce better, more effective services or health products or tools for our patients in clinical practice. I suppose the most important thing to note with this definition is that it has been criticized to some degree because it really focuses maybe a bit on a unidirectional approach where you could, by reading this, just assume that knowledge translation is only focusing on how we can adapt research evidence for use in policy or practice, but that it doesn't really acknowledge that it's a two-way street between researchers and also those knowledge users, so people in policy, people on the ground, health practitioners, the patients, and the public. So we want to really acknowledge that it's a two-way street between how policy and practice can also inform research design questions and conduct. So to fix that relationship, you can see here on this slide that knowledge translation, if you want to visualize it, is really at the overlap of the processes of how we conduct research and the processes of how we develop policy and how we implement those policies and research evidence into practice. So probably there's more consensus around the central domains of knowledge translation, and here are the main four. So we have knowledge production. So that's really what we've just been discussing, is how we design and conduct a research question through clinical trials or other different research designs, how we synthesize that knowledge, so how we tailor it for the different knowledge users that we're trying to engage with, and how we manage that knowledge, so how we can take the knowledge that we've created and actually make sure that it reaches those knowledge users. And then knowledge utilization, which is largely around people who are going to be using or applying that information, so policy makers when they're developing different policies for healthcare, the healthcare practitioners when they're in the clinics trying to decide what treatments to use. That really is within this particular domain. So if we think about what it would look like if we are really engaging with knowledge translation between these three different spheres of research, practice, and policy, we could say that we would end up with better collaborative research projects. So projects that involve not only the lens of the researcher or the scientific community, but also the lenses of the healthcare practitioners, the public, the patients, and the policymakers, to ensure that we do have better research questions that will help improve practice. So we could also ensure for the research agenda, so the questions that we're actually looking at in research are matched very well to the policies and priorities of practice. We would also know that our knowledge would be synthesized and tailored specifically for the people who we want to use that knowledge, so not just published in a journal, but making sure that information is translatable for the physiotherapist, the physician, or the person in government who's running a policy about that particular topic. So while this would be great, so if we had the translation of knowledge between research and policy and practice as a seamless, I guess, transition, we would be able to see these things, but it's actually much harder to do in practice. So some of the approaches that we can use, the most two common ones, would be knowledge synthesis, which really does involve how we take the knowledge that we're creating and tailor it for the particular knowledge users, and hopefully we'll present another webinar series on knowledge synthesis. But knowledge brokering is the other more complementary, I guess, approach, and I think we're going to hear a lot more about that now from Professor Coombs in BC, who has a lot of experience in this particular approach, and we're really looking forward to hearing her talk.
Thank you. Thank you, and good morning to those of us here in BC, and good afternoon, almost afternoon, to those in Newfoundland and people from all across the country. First of all, my thanks to the Newfoundland and to the BC support units for enabling this opportunity. And being cognizant of the time, because we started a few minutes later, I will ask for your indulgence if I skip or move a little bit more quickly through some of the slides. You'll still be able to access the full slide deck with the recorded session, so don't be concerned if you feel that we didn't spend enough time on any given slide. So how are we going to spend our time together today? I'd like to provide a perspective on knowledge brokering in healthcare in specific. I want to emphasize that it's a perspective, that this is an N of one, based on both my understanding of the literature as well as my lived experience. Now, CIHR has changed the term lived experience, is now preferable to use the term personal experience. So you could read that slide that way as well. So moving on now. There's a lot of information out there on knowledge translation and increasing amount in knowledge brokering. So I hope this won't be overwhelming. Similar to drinking from a fire hose, I've tried to select the most pertinent information. So a little bit about first, what I do now. I'm a KT specialist at the BC Support Unit as of January, on secondment for 2 years from my pre-existing position as a knowledge broker within physical therapy in the Faculty of Medicine at UBC. My role in the BC Support Unit is to focus on the KT, the Knowledge Translation and Implementation Science Methods Cluster, as well as developing the other methods clusters and facilitating collaboration between the methods clusters. So for some of you, those might be new terms, such as what is a methods cluster. So I'll give you a little bit of background. There's basically 2 main pillars for the BC Support Unit. First of all, on the left, the services, or supporting the doing. So there's services for researchers to support them in patient engagement, training for patient-oriented research, knowledge translation, research methods, letters of support, items such as that. We have another arm of the support unit that focuses on the study, on the science of each of these domains. So we presently have methods clusters in KT and implementation science, patient engagement, data science, health economics, and real-world clinical trials. The intent of the methods clusters is to advance the science and to develop the evidence base in methods in each of those specific areas, and to create communities of practice for methods. So that's what my focus is here now. If we look at the organization of the BC Support Unit, in the middle, these dark blue dots represent our regional centers. So we have a distributed model. We have our Vancouver Centre, but we also have centers in Interior Health, in Northern Health, in Island, and in Fraser Health. Surrounding that, then, we have our methods clusters, which I just described, and then our partner organizations in the blue. Then we also help to support the networks that have been developed, as well as 2 demonstration projects. So I'm just providing that as a little bit of context for what I'm doing now. But I'm really interested to know a little bit about you. So first of all, if you could just indicate for me the categories which best describe your current role. So you might be doing more than one thing, so please feel free to select more than one. So if you go to your polling option, can you let me know if you're a knowledge broker, a healthcare provider, a researcher, administrator, student, and other. And if one of those categories doesn't describe what you do well, please feel free to fill that in the chat box. And I'll take a sip of water while you fill that in. So I think we almost have everybody. So Eva, if you could just let us know. Oh, another person has indicated in the chat box, Melissa, that Melissa's involved as well as in patient engagement. So let's look at the results of that. We'll see that most people didn't fit one of those roles. And we had 21% of people that fit the other category, students and other, and we had 14% of the people attending today actually classify themselves as knowledge brokers. So let's go on to the next question. Can you please indicate your level of familiarity with knowledge brokering? Very, moderately, minimally, or not at all familiar? And it looks like we've got almost everybody has replied. So Eva, if you could show us what the results were. We can see that most people said that they, in the C categories, that they're minimally familiar. Some people did not reply, 42% didn't reply, 32% said they're minimally familiar, and 21% said they're moderately familiar. So I hope that the content then that I have prepared for this will address particularly the minimally and moderately familiar with knowledge brokering. So part one here is providing some context. What is KT, why is it important, and why then knowledge brokering? So Dr. Bev Holmes and Dr. Marla Steinberg here in BC provided a KT 101, the first session in the KT 101 series called KT Connects. And they coined the term turmoil. There's over 100 terms that are used to describe knowledge translation. And my view is that KT is more of an umbrella term. So what I mean by that is if we look at this linear continuum, and nothing is ever linear, but for the purposes of simplicity, let's pretend that it is linear. And you can see in the first box on the left, we have creating knowledge. That's establishing the findings, and usually from a single study. When we synthesize those findings then, we're bringing them together either in a systematic review or a meta-analysis. Then we're disseminating them, we're sharing those findings. Then those that are appropriate to implement, we are using them. And then after that, we monitor, evaluate, and try to sustain the use of those findings. And that's, we need to assess the use, the impact, and ensure continued use. Some people consider the disseminate and the implement only as knowledge translation. However, there's an increasing recognition that knowledge translation covers this entire continuum, because to do creation of even a single creation of knowledge well with a single study, good integrated KT will benefit and create better results so that the results are more meaningful and applicable later for dissemination and implementation. So again, to reiterate, knowledge translation, from my perspective, involves this entire continuum, although it may not be linear. So what does the evidence show about knowledge translation? Well, if we look at just one of many papers in this area, Gerlach and Dupreez from 2008, they stated in their review the magnitude of the mean effect sizes are at least 2 to 3 times higher when programs are carefully implemented and free from serious implementation problems. And that careful implementation means an implementation plan that is founded on KT principles, KT tools, KT resources. So what we're trying to do is moving from the previous, where we simply let things happen, we just present and publish and hope that it will be adopted into practice, to helping things to happen, so being more purposive and targeted in sharing our findings, to actually using known strategies that have been shown to address specific barriers to implementation. So that's making it happen. And we hear from people that they need help, and they need people who are trained and experienced in knowledge translation to do that. KT, this is from a knowledge, many of these slides here today, and I do acknowledge at the end the source of many of these slides. I was fortunate to take part in a 6-month KT program through the St. Mike's program in Ontario. And I like this slide of theirs, that KT is the key to the black box of what happened. So then a miracle occurs. We should be more explicit about what happened in order to enact the changes. And that's what the KT is all about. So it's, although we need to show that an intervention is effective, we also need to have effective implementation. And we also need to ensure that there's an enabling context in order to secure the better health outcomes. So KT is really about this green and this purple circles, spheres, because we should already have the evidence, but that alone is insufficient to provoke change. So let's move on to the next part of today then, which is what is a knowledge broker and what does a knowledge broker do? So this is not a scene that is common for me, where you're at a party and somebody says to you, so what do you do? And you say you're a knowledge broker. Classically, that's a good way to get people to exit from the conversation. Because it's one of those terms that, because of the term broker, people assume it's like knowledge broker or insurance broker, where you are paid a commission per exchange of information, and I can assure you that is not the case. It's also difficult to describe in elevator speak, in 10 to 15 seconds that you get to have a conversation in an elevator. But I will try and explain to you now how the literature and how I explain to people what knowledge brokering is. I usually start with some keywords that are used. And the first one that I use is that a knowledge broker is an intermediary. They're a bridge or a boundary spanner, a person that exists between worlds, between the world of the researcher, between the world of the clinician, between the world of the patient, between the world of the policymaker. They also act as a catalyst, a facilitator, and help to translate the information into language that is more meaningful to each of those stakeholder groups. I like this definition from CHSRF in 2003 that says that they're the human force that makes knowledge transfer or the knowledge movement of knowledge from one place or a group of people to another more effective and is distinct in aiming to bring people together for mutual advantage. So this slide to me captures the key terms that I use to describe what a knowledge broker is, and how a knowledge broker is distinct from other similar roles that exist in healthcare. But I can assure you that I don't dress like that. Okay, so what are some of the characteristics of a successful knowledge broker? Well, there was a series of articles that were published in 2013 in a UK journal. And they did an analysis of the knowledge brokers that are working in the NHS in the UK. And these are the key characteristics that distinguish successful knowledge brokers from those that were less successful. And those were knowledge, skills, and credibility in all worlds. And the credibility I have highlighted because it's very important when you are trying to facilitate change in behavior or change in practice, that you're not seen as one of them, that you're seen as one of us. So familiarity and credibility within the world, not as that you come in as an external person, but as an internal person, is really important. It's not just about the knowledge and the skill. It's also about having an extensive network of key stakeholders. It really is about relationships. And familiarity with and relationships, existing relationships with researchers, policymakers, healthcare providers. I consider myself a little bit of a jack of all trades and a master of none because I cross those different worlds. And the ability to facilitate reciprocal understanding. Understanding that researchers use different terms than healthcare providers who use different terms than patients, and helping the understanding between that. And then to be able to identify the potential for new linkages, to say, oh, I hear you talking about this, I know about so-and-so who's doing this, perhaps we can get in touch and see if a collaboration is possible. And when we look at those characteristics, you wonder, are those trainable characteristics or those innate characteristics? The old nature versus nurture argument. And I highlight the work of Dr. Vicki Ward here, who's written a tremendous amount in knowledge brokering. And I would encourage you to check out her blog, and she had one blog in particular about this particular debate. Is good knowledge brokering, is it nature or versus nurture? I don't have an answer for that, just like the nature versus nurture debate as far as parenting. But I encourage you to check out her blog. So really, who is a knowledge broker? Well, the title, the role, the activities are quite variable. So in that slide where I asked you to identify how you identify yourself, not everybody who does elements of knowledge brokering is called a knowledge broker. There's multiple terms out there that people use. Knowledge specialist or consultant, a knowledge exchange specialist or consultant, a knowledge translation specialist or consultant, or knowledge mobilization specialist or consultant. And those are just some. Like, I'm sure there's other terms, and please feel free to type in the chat box if you're familiar with another term that's used for a role in knowledge brokering. Many individuals actually function like knowledge brokers, but they don't possess this or a similar title. So opinion leaders in an area of practice could function like a knowledge broker, although they don't have that term. Academic detailers, people who come in to assist clinicians in particular in learning new elements of practice, they function like knowledge brokers. Knowledge boundary spanners, knowledge managers, project managers, change champions, and I'm sure there's multiple other terms. So you don't have to have the term knowledge broker to have in your job description functions that are typical of a knowledge broker. So then if we have to look at the essence of what a knowledge broker does, what does a knowledge broker do? Well, it's more than just moving knowledge. It's not just transferring it or disseminating it from one venue to another. And it doesn't have to be research to practice. It could also be practice to research or policy to research. It shouldn't just be a one-directional exchange. It's also about transforming that knowledge. And Mayer in 2010 stated that broker knowledge is knowledge that's more robust, more accountable, more usable. Knowledge that serves locally at a given time, and it's being deassembled and then reassembled into something that's more meaningful for that specific context. And the real value is in creating the relationships. So again, it's back to that. You see the link here with the characteristics of a good knowledge broker are those that, if we look back to that slide, were about transforming knowledge and about creating relationships. I don't know if you're familiar with the K-star theory. The K-star theory was really coined in 2012 here in Canada in the K-star conference that was held in April. And star is like the use of star after K indicates like a truncation symbol when you're using PubMed or CINAHL or any of the databases for a literature search. It's supposed to be like a truncation symbol. So it could be knowledge mobilization, knowledge translation, knowledge dissemination, knowledge implementation. The asterisk afterwards means it can be any word after knowledge. And they proposed this diagrammatic representation of knowledge brokering, where you start with an information intermediary, and this might be somebody more like in a librarian type of role that accesses the information from more than one source. And then you have a translator who helps make sense and apply that information. And then a broker who actually improves on the knowledge use and decision making and fosters the co-production of knowledge. And you'll see that these ovals overlap. So the knowledge broker is doing what the knowledge translator is doing and doing what the information intermediary is doing. And then there's this part over here, which I call walking on water, which they influence the wider context to reduce transaction costs and facilitate innovation. So I have yet to have the skills to enter that domain. But as you can see, it's moving along the continuum from informational functions to relational functions and then to system functions. So I draw your attention to this paper if you're interested in learning a little bit more about the K-star theory. So if we had to summarize the three critical components of what does a knowledge broker do, first of all, it's about knowledge management. It's about making that evidence more accessible and more tailored. Second, it's about facilitating mutual learning. It's about causing those linkage and exchange opportunities. And then finally, helping others to develop skills and capacity for evidence-informed practice, the capacity building arm of this. And this has been consistent in the literature. We can go back even as early as 2005, and most recent systematic review by Bornbaum et al. In 2015, where these appear to be the three essential roles. However, a colleague and I, Stephanie Glegg, who works here in BC as well, published a paper recently on a new model for the different role domains in knowledge brokering, specific for the healthcare setting. And here's the URL if you are interested in accessing that article. It's in the Journal of Neurological Physical Therapy in 2016. And in addition to those roles as the information manager and the linkage agent and the capacity builder that existed in the other literature, we've added facilitator and evaluator. And if you want to learn a little bit more about this model from a unique perspective as far as knowledge translation, how we disseminated this information, I suggest that you just click on this link because we have a video abstract of this model on YouTube. And I would love to hear your feedback. So please, if you have the time and a glass of wine over the long weekend, we've got 4 days coming up, and you want a little entertainment as well as edification, check out this 2-minute video and please let me know your thoughts. So we're on the home stretch now. We've got the last two parts that I want to cover is first of all what the evidence is and then what I've done in the past. So what is the evidence regarding the effectiveness of knowledge brokering? Well, Bornbaum in 2015 did a systematic review looking at both the function, so those three roles, again, of knowledge brokering, and the effectiveness of knowledge brokers in healthcare settings. They looked at 8 different databases, over 7,900 records, 240 full text, and 29 articles. 8 of those looked at effectiveness. 2 of those met standards of rigor, and their conclusion was that there is evidence of changes in knowledge, skills, policies, or practices, but as you can see, the N is quite limited for this. So if we had to look at the broader literature, if somebody asked me to summarize in just one slide, what is the evidence for it? I would have to say that it's inconclusive. And the reason that it's inconclusive is because I think of a number of reasons. There's a heterogeneity in roles. Not all knowledge brokers are doing the same thing. So how can you put all of those things together and say they're effective or not when there's quite a bit of variety in what knowledge brokers are doing? There's also no established measures of success. What are the metrics for success? There's also considerable variability in an individual's knowledge and skills in knowledge brokering or any activity. There's variable populations from mental health to community to pediatrics to knowledge brokers work across all domains, and perhaps their effectiveness is going to be more effective in a certain setting than another setting. So when you put that all together, you dilute the possible effectiveness because it's just too heterogeneous. Now, I think you could say this for anything. So how could you say that nursing or physicians or dietitians are effective or not effective? There really is, there's so many different reasons and settings and personal skills and organizational issues that influence effectiveness that I think that it's really quite unfair to look at effectiveness across a single discipline. However, there was a paper that was just published a month ago by some colleagues who were doing some work in social network analysis. And what I mean by this is not Facebook, Twitter, etc., but the ability of people to create new relationships and to enrich existing relationships. And that's called social network analysis. So this was a case study that came out of Australia. And they plotted the density as well as the extensiveness of relationships that were brokered by that knowledge broker. And what you can see is that when you compare in the 3 and 12-month periods, that the N's are the knowledge brokers, the N's here in white are the knowledge brokers, and then the grays are the relationships that were established because of the knowledge brokers. And you can see that the density as well as the extent of those relationships was certainly enriched by the knowledge brokering experience. And forgive me, I'll just make sure. They had 192 persons involved, 40 different organizations. And they were able to show that the increase in density was related to more cohesive, indicated more cohesive relationships. So, in the final part here now, I want to talk a little bit about my lived experience of how I undertake this as a knowledge broker. So, my knowledge brokering experience started in May of 2009 in a 0.5 position as a knowledge broker. This is a unique knowledge brokering position, as in there were 4 equal funding partners: the university in the Faculty of Medicine, the Department of Physical Therapy, the Association of Physical Therapy in BC, and then links to the research and practice domains of 2 healthcare authority research institutes. This unique combination enabled leverage from the academic setting, from development of curriculum, from frontline clinicians, from research. So it really was a successful, I think, partnership that you wouldn't see typically in the funding of a knowledge brokering role. I'm not going to go read through each one of these activities that I've done. You'll be able to get copies of these slides from the recording. But as you can see, things like grant applications, bringing together stakeholders, co-creation, synthesis, that whole continuum that I showed you at the beginning was a reflection of the scope of the activities that I did as a knowledge broker. And if I had to summarize those into one major category, it was about enabling, and not in the context now. Often the term enabler is kind of seen in a derogatory way. In this way, it's seen in a very positive way to leverage or establish connections, the ability to assess a context, both internal and external, to look at what are the needs in that context. Is there readiness for change? To facilitate and enact KT science-informed KT plans, and to develop KT and knowledge brokering capacity in BC. So those are the major things, the major pillars of what I did as a knowledge broker. If we look at some of the outputs and outcomes that are a result of that, and recognize that this is an N of 1, but it really was only possible because of over 350 people who engaged in the 23 projects and resources that were developed. None of these involved funding. These were 350 people who became involved in the projects because they saw value in them, and they did it off the sides of their desks. We developed 23 resources which have been accessed over 232,000 times from over 200 countries. We've established those resources on a number of different websites. And if we look at the metrics, people spend 1.5 and up to 9 times as long on those resources as they would clicking on another resource. 26 projects were undertaken, over 60 presentations locally, provincially, nationally, and internationally, 25 publications, 182 citations, 80 grant submissions, 36% of which were funded. Now the normal grant funding ratio is around 15%, so I think this speaks to the partnerships that were possible because of having a dedicated knowledge brokering role, and over $3 million worth of funding for those grant submissions. Of course, the golden goose is, does it change practice? Well, that's hard to test in a randomized controlled trial because how can you deny people access to a resource that has been developed? But one of the resources that we did develop was called the Achilles Tendinopathy Toolkit. It's been downloaded over 80,000 times from over 200 countries. And when we did a survey where we gave a hypothetical vignette, we gave people questions about how they would manage these particular scenarios with Achilles tendinopathy. We found that those who reported that they were familiar with the toolkit were twice as likely to use the evidence-informed interventions that were recommended in the toolkit. Okay, so home stretch here, part 6, final slides. What are the key lessons? What would I say to you for somebody starting as a knowledge broker? What are the key lessons? Number 1, be clear. Are you talking about science or are you talking about practice? As far as practice, that's the doing. It's the use of strategies to adopt and integrate evidence-based interventions and practice change within specific settings. So that's the doing. But then there's also the science or the study, and that's the scientific study of methods to promote the uptake. Those are things like, should you use audit and feedback? Should you use an opinion leader? Should you use pamphlets? Should you use an education session? That information, you need to marry the two to be able to, you can't do practice, can't do the doing without incorporating the information from the science, and you can inform the science by evaluating your doing. So that's my first main message. My second main message is don't expect a single formula for the KB role. For some people, it's part of an existing role. For some people, it's an isolated knowledge brokering role only. Sometimes they're full-time positions, sometimes they're part. Sometimes they're contracted for only one project versus sometimes for a more permanent position like the one I just described. Sometimes they're just a specific project versus a specific role. There's other related roles. There's KT agents, and I understand in Newfoundland there's also brokers in specific rural communities. So there really is quite a bit of variability. So there isn't a single way of doing it. Also, select your KT approach. Think about whether you're trying to push information, and that's from really a researcher-driven agenda versus pulling it from a user perspective to co-creating, causing the linkage and exchange. And that will determine whether you're trying to let, help or make it happen, and whether your target is trying to increase awareness, change awareness or attitude, or change attitude and behavior. And remember that not all knowledge is ready to be transferred. A study of a small n and a single study doesn't mean that you have an actionable message that's ready to be translated or implemented into practice. Make sure you assess the barriers. Know what's going to block your progress. Know where you're going to get stuck, and know when you're going to what you're going to run into. Assess the context so that you can identify strategies to address those barriers. And there's a bunch of them out there. There is a plethora of great tools, frameworks, models to help you to, once you've addressed those, first of all, to identify those barriers, such as the Consolidated Framework for Implementation Research, and then how to address them. And that's a whole lot better than the ISAGLAT approach. And the ISAGLAT approach stands for it seemed like a good idea at the time. Let's put a science behind it and not just guess what we should be doing. And finally, keep learning. There's increasing options available now for training in KT. There's a few more options for formal training for knowledge brokers. You can start communities of practice in KT and knowledge brokering. And you need also to be able to establish criteria for selecting knowledge brokers. And if you aren't already involved in a community of practice, perhaps start with the Canadian Knowledge Transfer and Exchange Community of Practice. My parting thoughts, there isn't a formula, but there are critical elements and multiple resources. And there's ample room to shape the role and the activities of a knowledge broker. And finally, Anonymous, who's written an awful lot, tells us if we keep doing what we are doing, we'll keep getting what we're getting. So it's time to be a little different in what we're doing so that we get and make it evidence-informed so that we get different results. Everyone starts somewhere, and if we look at the most successful groups or organizations, they all started in garages. So we start somewhere, and I just want to acknowledge the sources for many of these different slides and open it up. Thank you, the Newfoundland Support Unit, the BC Support Unit, all of you who are on the line today, and those of you who will access this in the days to come, and the over 350 people that I've had the pleasure of working with. I have added 2 slides that you can access later, just as a sample of KT and knowledge brokering resources and training available that you can access yourself from anywhere. And I'm a major Twitter follower in knowledge brokering, and I've provided some Twitter handles of some great people that I follow. So here's my Twitter handle at PhysioKTBroker. Here's my email address at the support unit, and now I open it up for questions, concerns, thoughts. So that's always a concern. Perhaps I'm overwhelmed, or it's people are thinking about the long weekend already. It's just the start of the day in BC. It's now 8:51 a.m., but people are maybe thinking about those Easter egg hunts across the country. Melissa says, thanks, Allison. Thank you, Melissa. Thank you for joining. Look at this, a couple of people have left, which means they feel that's great. We've covered the material, hopefully, that they were hoping we would cover. No further questions. Ava, do you have any questions? Anything you would like addressed?
I see that a few people are typing, Alison. So there is a question here from Andrea, and there are other couple of people typing. So would you be able to answer those questions first? Thanks.
So I see the question from Andrea. I'm a staff development educator with interior health, and a barrier I often see is information overload and disengagement. What are your thoughts re multiple priorities? Excellent question, Andrea. You know, it's a whole lot easier to support change when that change is welcomed, when people don't have a whole bunch of competing demands. I try to leverage, of course, where possible, things that are already occurring and point out, for example, a great time to enact change is just prior to accreditation. So if you work in a healthcare setting, you know that every couple of years you go through the accreditation process. If you can identify in advance what the key criteria are for accreditation that year and link your project to that accreditation need, then you'll have an impetus that will help you to facilitate that change. Disengagement, my experience has not been a problem with disengagement. As you can see, with over 350 people that have joined the projects and the numbers of people who have accessed them, I think that's an indication of making sure that you don't embark on a project if it isn't meaningful to the people that you're working with. So one of the first things that I do is doing a needs assessment and assessing the context to ensure that there already is a level of interest that is sufficient to be able to enact passion or activity. I've never had a problem pulling people into work on a project because that project, not me, but that project has inherent value to them. So if you really understand, help to understand what's important to those individuals and put it in those terms, my experience has been that there hasn't been a problem in getting people to engage. I don't know if that addressed your question adequately, Andrea. If not, please feel free to type again. Lisa says, thanks, lots of resources. Thanks, good, yeah, please feel free to try out some of those resources. Andrea says, competing with those, yeah. If, you know, I have to say that if there are a whole host of things that are being tried at the same time, it's very, very difficult to make yours a priority unless people also see it as a priority. Janet says, thank you for a great session. I look forward to going over the information again and following up on resources. Thank you, Janet. David said, are there any particular tools that have been helpful in research knowledge brokering? David, I'm not sure what you mean by that question. Can you give me a little bit more description of what you're looking for? Do you mean in researching knowledge brokering, like ways of assessing effectiveness, like systematic review, meta-analysis, that social network analysis? I'm not sure if you're talking about methods or not. Mike says, thanks, Eva and Alison, lots of knowledge transfer here. Thanks, Mike. Enjoy your weekend, you too. Thank you, says Andrea. Ava says, another question from David. I'm just wondering, says Kristen, if most KBs have formal training or certification. If not, is there such a thing? There is a program a knowledge brokering program offered by Melanie Barwick. If you Google Melanie Barwick, she does have a knowledge brokering course. They're often a part of other KT courses. The backgrounds of knowledge brokers are very diverse, and as I said, I think the community that you work in, you have to have the credibility. So I think it's good that there's diversity in knowledge brokering. There should be nurses, there should be OTs, there should be PTs, there should be dietitians, because we need that credibility. It is a diverse and interesting field. You're quite right. And thank you for the compliment. David says, when trying to show research results, is there a particular method that's been shown to be more successful? David, good question, and I think it depends on what you are trying to measure. So if you're trying to measure, for example, the ability to create relationships, social networking is great. If you're trying to show that knowledge brokering is effective in getting more grant applications, then tracking the grants submitted versus the grants, the number that are successful, that's a great metric. If you're looking at relationships and building capacity, another metric that I look at is how many first-time authors could I help as frontline clinicians, their first research experience, first authorship. And we just recently had a paper published that we won the Silver Quill Award with frontline clinicians who had never published a paper before. So I guess my short answer to that is the metric for measuring success depends on what it is that you're trying to show. David said posters, interactive materials. Oh, I think what you're trying to ask there is there a particular method for disseminating information which has been shown to be more effective? David, the answer to that is it depends on the barrier. If the barrier is knowledge, if the barrier is awareness, posters can be effective. If the barrier is behavior changes, posters aren't going to have been shown not to be effective at all. It has to be more things like audit and feedback, or an opinion leader. If you want change in attitude, opinion leaders have been shown to be effective. Christine says, David, I don't know, we've got 1 minute, so this is the last question. David, I don't know if this helps, but the KT planning tool by Melanie Barwick grants effectiveness of various KT strategies. Yeah, it's a great tool. Thank you, Christine, for that idea. So I see we're at 9 o'clock, so I'm going to stop talking and let Ava wrap up.
Thank you, Alison. So thank you so much for this excellent webinar. We learned a lot here in Newfoundland and Labrador. At least I learned a lot. I would like to let you all know that it was the last webinar of our training program for those who are part of our certificate program. But please save the date, because we have another special workshop coming up in collaboration with CADET. So Ken Bond, the Director of Patient Engagement and International Affairs from CADET, is coming to Newfoundland and Labrador, and he will give a presentation during our Health Economics and Education Day on June the 7th. And then in the afternoon we have Hay, our health economist from the School of Pharmacy, who will give you an introduction in health economics. So save the date, and we will soon announce this workshop on Eventbrite and give you the opportunity to sign up. It will also be shared via our newsletter and by email. I hope you enjoyed this session. If you have any further questions regarding KT, please know that our KT specialist, Amanda Hall, is also available for support. So if you have any questions about methods or tools, or how to best integrate KT in your grant or your project, she would be happy to assist you with that. So if there are no further questions, then please fill out our survey. We would be happy to hear your thoughts about this session. We will share the link by email as well as the presentation, and the recording will become available on our website and YouTube channel. Thank you all in BC. Have a wonderful day, and for those in Newfoundland and Labrador, hope you have a wonderful Easter weekend. Thanks.